Now we will also discuss some of the monitoring aspect in the subsequent slides. Now for the nurses, it is very important that for the nurse to know that she has a very vital role to perform. Now oxygen nurse is a concept that has been floated recently when we have started performing the oxygen audits. Oxygen nurse can be a vital source of information also, and vital source of a weaning protocol also. So she is the one who can do pulse oximetry in the ward. She can turn off the oxygen flow meter when the patient is not using oxygen for any reason. The oxygen nurse can instruct the patient from time to time about the importance of oxygen administration. She can also help the patients to disconnect oxygen when it is not required. For example, when the patient is eating or drinking, then temporarily it can be suspended. So she can request the patients to call them or call for assistance whenever they do not require oxygen for any purpose. The oxygen nurse also should educate the patients to prevent the patients from handling the oxygen knobs. This is very important aspect because of the misconception of most of the patients that if they get oxygen flow at higher flow rates, or if they increase the knob, or if they change the settings, then it is going to be beneficial to them and they will recover early. This is a misconception, and so the oxygen nurse can help them to prevent them from turning or switching the knobs. CARP protocol is one which is to be followed. Everyone knows about CARP protocol now, and it is a very simple protocol in which the patient has to assume certain positions, say left lateral position, then upright position, then right lateral position, prone position. These are all positions that can be given alternatively, and for designed protocols, say for example 2 hourly changes in position. Once you implement these type of protocols, there is a lot of saving in the oxygen, because scientifically it has been proved that oxygenation improves in prone protocol. Care of oxygen delivery system, regular cleaning of humidifier bottles. The recent upsurge of mucormycosis has led us to all introspect ourselves that why this mucormycosis pandemic has occurred amidst this COVID-19 pandemic. Now one of the reasons, important reasons, is the hygiene of the flow meter bottles. So if the hygiene is not maintained, then mucor can grow into it and it can invade the body tissues and create a havoc. Like we have seen rhinocerebral forms, we have seen ophthalmic forms, and we have also seen in some patients aspergillus infection of the lung. So all these can be prevented by regular cleaning of the humidifier bottles, checking for the oxygen flow, checking for the blockages at the outlets of these flow meters, using sterile distilled water only for filling the bottles, and checking flow meters for any leakages. All these should be a part of the working protocols of the staff nurses, and one day should be assigned in a week to maintain all these protocols. If at least once or twice a week all these checkings or checklists are signed, then we will surely be able to reduce the incidence of mucormycosis. Now for the patients, we must display certain do's and don'ts. Every patient must realize the importance of an oxygen bed that they have got. There was a time, or there in some places it is still existing, that patients are worsening because of lack of an oxygen bed. Now for the do's, they should inform the staff if there is need to take off the oxygen mask. They should inform in case the oxygen flow is not sensed. Sometimes it may so happen that the outlet is blocked and the patient may not sense any oxygen. So in that sense also, the patient has to inform the on-duty staff nurse. The patients also have to maintain a good hygiene at the oxygen mask level, because if the mask is not handled properly or it is handled with unclean hands, it is likely the patient may get a secondary infection. It may be a bacterial infection or it may be a fungal infection. The don'ts in this case are: do not handle the oxygen flow meter knob. Do not take off your O2 mask unless instructed from the on-duty nurse. For example, some patients may not handle the knob, but they might want to remove the oxygen mask either because it is very tight or whether it is because of too loose fitting. Now in such circumstances, it is always mandatory that the patient should inform and not carry out all the adjustments on his own, because During these changes or adjustments, there is likelihood of loss of lot of oxygen, leading to lot of pilferage at their point. Now they should also be instructed to not to handle or adjust other patients' oxygen settings. So it should also be instructed to other patients to inform the on-duty staff so that they can do the needful. Now let's consider oxygen management in the ICU setup. Most of you are already doing a rationalized management of patients. Most of you are already following the weaning protocols, but yes, it is time to reinforce these, and maybe we can take this opportunity and train our junior doctors so that they can perform oxygen weaning as good as we do. So if the patient has persistent hypoxia on 100% FiO2, then we can think in terms of how to improve oxygenation. First thing is we have to consider other ventilator settings. So we have to look at the ABG. Now ABG is arterial blood gas analysis, as all of you know. So arterial blood gas analysis is a mandatory thing for every ICU patient. ABG PO2 levels will help us to guide about the FiO2, and PCO2 levels will also help us to decide the respiratory rate and other things. So we can carry out certain procedures or certain ventilator setting changes that will help us in saving oxygen. PEEP. Now PEEP is positive end expiratory pressure. We can increase the PEEP levels. We can go from say a set reading of 5 centimeters to even up to 20 or even 25 centimeters, depending on what is the type of lungs involved. If the lung compliance is poor, a higher PEEP setting will help in oxygenation. This PEEP adjustment might not be useful in patients with normal lung compliance. So always the compliance reading on your ventilator should be checked and the patient's PEEP should be set accordingly. The inspiration-expiration ratio. Inspiration-expiration ratio has got a very vital role, because when you're managing most of the COPD patients, the obstructive airway disease patients, they benefit with prolonged expiration. But here, if oxygen saving or improving of oxygenation is desirable, one can adjust the inspiration-expiration ratio. Normally set ratio is 1:1.5 or 1:2. Now this ratio can be altered to 1:1 also, so that the inspiratory time increases and the lung oxygenation is improved. Similar way, changes in the tidal volume and changes in the respiratory rate can be made so that the patient oxygenation improves. Now these changes, tidal volume changes and the respiratory rate changes, should be adjusted according to the condition of the patient, according to the PO2 and the PCO2 levels that have been measured through the arterial blood gas analysis. In some ventilators, there is an additional setting called as airway pressure release ventilation. This is also known as APRV, and this setting can be used to our credit in most of the cases as it improves the oxygenation. So similar ways and means should be sought to improve oxygenation if the patient is still requiring 100% FiO2. So FiO2 is not the only parameter which should be changed or which should be increased to improve oxygenation. This thing should be kept in mind by all the on-duty doctors, and they should have a hospital committee where such cases in which the FiO2 is persistently high but the patient is not weanable, such cases must be discussed across table with the senior faculty, and changes in the ventilator settings should be carried out so that excess oxygen is not delivered to the patient and there are less hazards of oxygen toxicity. Now there are two more angles with which I would like to see hospitalized ICU patients. Now one is we have to consider alternative diagnosis. For example, in some patients the diagnosis may be congestive heart failure in addition to the ARDS. If congestive heart failure is missed, then the patient will not improve despite your oxygenation protocols. So it is very important that one uses diuretics or cardiac supportive measures in such cases to improve oxygenation. It is very easy to recognize congestive heart failure in ICU settings. One can get an ECG, a bedside 2D echo, pro-BNP levels monitored to detect congestive heart failure and manage it appropriately. And that therefore such patients also need a central venous pressure monitoring. Now alternatively, pulmonary embolism is missed on most of the occasions because it happens so that the patient has directly arrived into the emergency room and is taken into the ICU, and in such a setting it is not possible to shift the patient for a CT pulmonary angiogram. In such cases there should be a high index of suspicion. Few pointers like persistent rise in D-dimer levels, ECG findings of pulmonary embolism. There are several ECG findings, one can go across literature and monitor the ECG changes. Then last but not the least is 2D echo, in which you can get a dilated right atrium and right ventricle so as to diagnose a pulmonary embolism clinically. And in such cases, a continuous infusion of heparin 1000 units per hour or increasing the doses of low molecular weight heparin can be carried out, and the oxygenation seems to improve drastically. So that is why it is recommended that one reconsiders the diagnosis if the patient is not improving in the ICU settings. So I hope we have at least sensitized the audience in terms of oxygen weaning and optimize the use of oxygen in ward as well as in the ICU settings for a better future, because oxygen saved is oxygen gained. Thank you.